Hello and welcome to our audience, joining us here at the Leading Systems Network for our first webinar of 2013. My name is Chu Yi Kut, Knowledge Coordinator at the Leading Systems Network, and I will be your host today. This year, LSN's webinar series explores the challenge posed by multimorbidity, the coexistence of multiple and commonly chronic diseases in the same individual. Around the world, multimorbidity is fast becoming the norm, not the exception. In this evolving context, healthcare that continues to focus on singular diseases will no longer be effective or affordable. Today, making the case for transformation of healthcare systems to meet this challenge, we have the honour of being joined by Gerard Anderson, Professor and Director of the Centre for Hospital Finance and Management at the Johns Hopkins Bloomberg School of Public Health. Welcome, Jerry, and we're very glad to have you with us today.
Well, thank you for inviting me. It's a pleasure.
Thank you. We're also joined by my colleague Jeff Spite, Executive Director of Product for LSN. Welcome, Jeff.
Hello, everyone.
And before we begin today, Jerry, could you tell us a little bit about your interest and work in this area?
Sure. So I started out, my first job was working in the Office of the Secretary in the U.S. Department of Health and Human Services in Washington. And what I was very interested in was healthcare costs, and essentially trying to control them first for President Carter and then for President Reagan. And I first of all worked on hospital cost containment, then worked on the DRG system and developing it. And then moved on in 1983 to become a professor at Johns Hopkins University, where I've been ever since, and have been pursuing, as you can tell, working in the United States unsuccessfully in controlling healthcare costs, but was always interested in who was responsible for most of the healthcare spending. And we looked at it in a variety of ways. And if you look at it, and you'll see about it in the data we see today, a lot of the expenditures are on people that have multiple chronic conditions. So I said, well, what is being done in the U.S. healthcare system to take care of people with multiple chronic conditions? And I said, not very much, and I'm going to talk about that today. Then I started getting calls from Europe and Canada and industrialized countries, which essentially said, we have all these people with multiple chronic conditions, and I don't think our healthcare systems are being very responsive to their needs. So that continued. And then more recently, probably the last 5 or 6 years, places like the World Bank, USAID, DFID, other international aid agencies have started to say, you know, chronic disease is a serious problem in low and middle income countries, and we need to do something as well. So for the World Bank, I did studies in places like South Asia. For USAID, it did Eastern Europe and South America and the Caribbean regions, all trying to get ready for these international aid agencies to be involved with issues of multimorbidity. So that's sort of why I got started, and now I'd sort of like to give you a sense of what we're learning about with it. So the first thing that I talked about, and the first slide, is the global picture of mortality. And essentially what we're seeing is where are people dying and where they're dying from chronic disease. And essentially what you see is for all ages, the predominant reason for death is something to do with chronic disease. And I think it's quite surprising for most people, not necessarily in the high-income countries, but the percentage of deaths, 87%, 88%, almost 9 in 10, related to chronic disease in high-income countries is, I think, for many people still quite surprising. We still think of AIDS as being a major killer and other things, but really it is chronic disease. And even among people ages 15 to 59 in high-income countries, it's almost 8 out of 10 people are dying from chronic disease. But now when we start looking at, Europe and Central Asia and East Asia and Latin America and the Caribbean, it's still a very large percentage. 3 out of 4 deaths are typically the result of chronic disease in these countries, and even countries like South Asia, it's almost 3 out of 4. It's only sub-Saharan Africa where the majority of deaths are not due to chronic disease. And we really don't have a healthcare system that's really oriented around these chronic diseases. So we're now trying to figure out how can we revise the healthcare system, be more responsive to these things. And as you can also see in this first chart, the percentages of illness or deaths that are associated with chronic disease are increasing quite dramatically, especially in the lower income countries. So a 39 percentage point increase in South Asia over just a short period of time from 2008 to 2030 are attributable to chronic, non-communicable chronic diseases, and a significant percentage increase in the 15 to 59 age group as well. Now, if I turn to the United States, where I did most of the work initially, what you see is it's not just people with a single chronic disease, but it's people with multiple chronic conditions. So, what we see is about a quarter of all Americans, and this is all age groups, have 2 or more chronic diseases, and about 5% of Americans have 5 or more chronic conditions. Now, I'm not quite sure how it works in all other countries because we don't really have that good a data on a lot of other countries, and as we start the discussion, I'll be very interested in your input as to what it is in Europe, what it is in Australia, what it is in Singapore and other places. But right now, what I've done looking at other countries, and mostly higher income countries in Europe, is these numbers don't look all that different in these other countries, but having the data for me is a very interesting thing in a variety of different number of countries.
Professor Anderson, this is Jeff Spite. So I wanted to ask you about that. One of the challenges that we've seen as we've gone around is that it's how do you define or how do you figure out they have a chronic condition or not, and which chronic conditions would you include into these studies? Because a lot of the things a lot of them are 4 or 5 major chronic conditions, but then, you can get the list of 40 or 50. So what has been your kind of view on that?
So we've gone back and forth this at least 100 times on the definition of a chronic disease and what constitutes one. So we essentially consider everything as a unique chronic condition. So what we've done is we first of all went through and had a group of clinicians at Johns Hopkins and other places go through and identify every single condition as being chronic, episodic, or acute. Everything in every single code book, and we've published this in a journal called Health Affairs, that list. Then we go through and we have a categorization done by AHRQ, one of the federal agencies in the United States, that has grouped medical conditions into categories. And they are called CCS categories. And so we have unique chronic conditions, and there's about a possible of 200 of them. We've also done it with smaller groups where it's only about 17 or 18 different categories of chronic conditions. And what we find when we start looking at the numbers is it doesn't really matter which chronic conditions you have in a number of things. It's how many chronic conditions you have that determines your outcomes and determines your cost, not which specific ones you have, because people have so many different myriads of combinations and permutations of chronic diseases that it's really hard to say, and we tried to do it unsuccessfully, to say, what is it like if you have diabetes and 2 other chronic conditions? What is it like to have COPD with 2 other chronic conditions? What is it like to have Alzheimer's with 2 or other chronic conditions? It's just really hard to to try to do all those different combinations, because Alzheimer's, diabetes, and COPD, that combination is just different than Alzheimer's, COPD, and some other chronic disease. So it's really hard to do it. All the different permutations, combinations make it impossible. And as I'm going to show you in the slides that come up, it really is just a nice linear trend in terms of cost and in terms of outcomes, just to do a simple count of the number of chronic conditions.
Great, thanks.
Sure. So why don't we turn to the next slide, and I think this will essentially illustrate it. So the first thing that we took a look at is, well, how many times will you have an unnecessary hospitalization? And what an unnecessary hospitalization is one that if care was provided in an ambulatory setting appropriately, the person should never be hospitalized. So, for example, you shouldn't be hospitalized for asthma. It should be taken care of in an ambulatory setting. And so there's a group of researchers out at UCSF and other places that went around and essentially identified what were ambulatory care-sensitive conditions or unnecessary hospitalization. And what you see in this chart is that the more of these chronic conditions you have, and again, undifferentiated chronic conditions, the more of these that you have, the more likely you are to be hospitalized unnecessarily. And what it tells us is that these people with multiple chronic conditions are just not getting their care coordinated. They're clearly sicker, and we need to do something special about these people because they're showing up in the hospital for a lot of things that they really just don't need to be in the hospital for. And so we've got to figure out a way to try to change the healthcare system to make sure that the care is better for them. And again, I've tried to do this in other countries. We've seen some similar studies in the UK and in Canada for doing these kinds of things, and the charts look reasonably similar. Then probably the next slide talks about Medicare spending and the fact that over 70% of Medicare spending is for people with 5 or more chronic conditions. Medicare in the United States, for some of you from overseas or outside of the U.S., is the program for the elderly and some of the disabled in the United States. And so what it was quite surprising when we were talking about reforming the Medicare system was that nobody knew in 2003 when I first created this slide was that such a high percentage of Medicare spending was for people with 5 or more chronic conditions. They just weren't thinking of the Medicare program, the program for the elderly, as a program for chronic conditions or people with multiple chronic conditions. And so all the efforts that have been started over the last 10 years, to some extent, and nobody should take full credit for this, but to a large extent are a result of slides like this, which essentially showed to the policymakers, both in the administration and in the Congress, that if they want to save money in the Medicare program, if they want to improve care in the Medicare program, it is these people with 5 or more chronic conditions that they really need to target. These are people that are having high rates of readmissions. These are people that are having high rates of unnecessary admissions, and all of this is adding to the cost and making it more difficult for them to receive appropriate medical care. So, what do we need to do to change? Well, basically, I think it's 4 things or 5 things that are absolutely critical. The first one starts with the evidence base. We really need to figure out how should we treat people with multiple chronic conditions. If you pick up the New England Journal of Medicine or any of the clinical journals, what you will see is routinely the people with multiple chronic conditions are being excluded from most clinical trials. Clinical trials done for drug use, for technologies, or just for good medical practice. We want to measure efficacy, not effectiveness. And so we typically, standard practice, we exclude all the complicated patients from the clinical trials. But the practicing physician really needs to know how to take care of the complicated patient, not the simple patient. And so what we're trying to figure out now is how do we modify either clinical trials or supplement clinical trials or use observational data or something like that to try to get a better evidence base to take care of people with multiple chronic conditions. And that's something that I am working with the NIH and the FDA, and I know people in other countries are doing the same kind of thing. The second area is medical education. I think we do a great job of educating physicians and nurses body part by body part. And what that means is we teach them how to take care of the diabetes or some other chronic disease incredibly well. But what we're less good at, and we're getting better at, but we're less good at, is taking care of the whole patient and try to figure out for them how do we essentially design the educational system so that they are trained to take care of the complex patient with 5 or 6 other things wrong with them, and to get the different physicians, the specialists and the generalists, to work together. And this is something that's evolving, but it's taking a slow amount of time, and it's really a challenge.
Jerry, especially in the context of what you were speaking about earlier about low and middle income countries, I've got a background myself in international development, and when I was working in the healthcare sector there, I did notice even stronger silos around disease specialities than I've seen in more developed countries. And given the emerging awareness of the burden of multimorbidity in those countries, do you think that there is potentially more room to innovate, or do you find that they are perhaps on a pathway where they could make this area even more difficult in future?
Well, my experience, and I don't want to badmouth places like the International Aid Agency too much, but the low and middle income countries really have mostly a focus on infectious disease as opposed to chronic disease. Although now if I go and talk to them, the health ministries are realizing quite intensively that they're having to deal with NCDs, non-communicable chronic diseases, a lot. But the international aid agencies haven't really caught up with the change, and so they're still working more on that siloed mentality and still developing health systems around that siloed mentality that makes a lot of sense for infectious disease, but makes much less sense for chronic disease and makes even less sense for multiple chronic diseases. So in summary, what I think we're seeing is the health ministries in many of these countries being aware of the multiple morbidities and the fact that, as I showed you earlier, half of the deaths, a lot of the utilization is a result of chronic and multiple chronic conditions, but they're having difficulty getting the attention of the international aid agencies, who tend to still be focused on infectious diseases and maternal and child health, which are still very important problems, haven't gone away, but what's come along, and they sort of missed the boat so far, is the fact that in a country like Bangladesh, where we're working right now, almost half of the burden of disease is non-communicable chronic disease. And the educational system in countries like Bangladesh has not kept up with the change in morbidity and mortality. And they are, again, trying to catch up, but as you can imagine, starting to train a physician today will take anywhere from 6 to 10 years to get them through the process. So even if we started in 2013, we're not going to get a lot of them trained until 2020, and then they're going to be practicing that new model for a period of time. We're going to have a lot of the existing physicians practicing under the old model. So this is a long evolutionary process, but especially for medical education and biomedical research, we need to start now because it takes a long time for things to get through the pipeline. So in terms of financing and delivery, I know you're going to spend a lot of time talking about those things. If I look around the world, what I essentially see is programs and delivery systems and payment systems and financing systems still very much focused on acute care and not chronic conditions. So to turn back to low and middle income countries, what we see a lot is we have insurance for an acute episode, a heart attack, but we don't have insurance for continuing monitoring of your diabetes. We just don't have an insurance for that. We don't have insurance for keeping your hypertension under control. We don't have insurance for your COPD. So people have to pay almost all of this out of pocket. What it means in terms of poverty is they get sicker, they can't work, they spiral down. Their spouse or their daughter or somebody like that needs to care for them, and they're taken out of the workforce, and it becomes more and more serious. This is clearly true in low-income countries, but even in middle to upper-income countries, it's a problem. Probably the poster child for this right now is Russia. Vladimir Putin is all over this issue right now. He has some money to deal with this, but he has made a major policy effort over the last couple of years to try to deal with the risk factors related to chronic and multiple chronic conditions, because what he has seen is that 35% of his men die before they're age 60, and many more of those people that are alive are having serious difficulties performing their jobs, which means that the economics of the country and the military readiness of the country is seriously compromised because of chronic conditions. And Vladimir Putin is just all over this issue and is trying to change the financing and delivery system to try to do it. Finally, in terms of quality metrics, if we don't have the evidence base for biomedical research, then essentially we don't know how to develop quality metrics. So what we've tried to do in the past is to take the evidence for dealing with an individual chronic disease, say diabetes, and then say if the person also has COPD, we'll merge those two guidelines and essentially put them one next to another, which sometimes makes sense, but often doesn't. When you have somebody with 4, 5, 6 chronic diseases, just putting together one after another really doesn't work as a way to say what is the best quality care for people. So what we're going to need to do is, going back to the biomedical research, is try to figure out how we're going to measure quality in a person that has diabetes, some beginning Alzheimer's, some beginning COPD, some diabetes, and other things, because taking each one of those quality measures and just saying they should get all those things often turns out to be poor quality care. So what I showed you and talked about earlier is the fact that we don't have an evidence base. And just for those people on the call that are working with pharmaceutical companies or device companies or involved in clinical trials as researchers, what we see is that we exclude an awful lot of the complicated people from most of our clinical trials. So 81% of the randomized clinical trials, and that's the standard of research in the world, 81% of those RCTs exclude people with common chronic conditions. If you're trying to figure out whether the person is getting better because of the treatment and they have diabetes and it's a diabetes drug, you want to exclude that person with COPD or something else. I mean, it makes complete sense when you're trying to measure efficacy. But now, as a physician, trying to figure out how to treat somebody who has diabetes and COPD, you're not sure the drug is going to work the same way for the person with multiple chronic conditions. 39% of randomized clinical trials routinely exclude people with who are older adults, and they are the ones who are much more likely to have chronic conditions, and half of them exclude people taking other medications. All of which makes complete sense if you're trying to measure efficacy, but most of the time it's a real challenge when you're trying to treat a patient when that patient would have been excluded from the clinical trial. So you're essentially saying, well, should I ignore the exclusions? Should I essentially say I'm going to keep the person on the existing treatment that I have, ignoring the new information because I don't know exactly what to do because my evidence base isn't all that good? So we need to change medical education, and essentially doctors typically feel very comfortable if they can treat patients. We did surveys of physicians in the United States, and what we found is they were exceedingly comfortable in taking care of acute illnesses. They were much less comfortable in taking care of chronic diseases and much less comfortable in taking care of people with multiple chronic conditions. So this is just one. This is a different survey that I showed you here, but in the United States, only about 2 out of every 3 doctors thought that they were comfortable in taking care of people with multiple chronic conditions. In some other countries, like Germany, it's quite high, 93%. In other countries like Canada, it's only a little better than half of them feel that they got the appropriate training to take care of people with multiple chronic conditions, or that they have the resources available to them to take care of people with multiple chronic. So given that probably the majority of their patients, maybe even 3/4 of their patients have multiple chronic conditions, the fact that they don't feel well prepared to take care of them is a serious problem that not just the United States, not just Canada has, but most all countries have. I'm not sure why Germany feels that they're so much better at doing this, but we could take a look at the training, and maybe they can, in fact, are doing something just a little bit better.
And Jerry, these are generalists, aren't they? These are people who are the best placed to treat people with multiple chronic conditions.
Yeah, this is surveys of general physicians in the country that are general practitioners or somebody like a general practitioner. So they, in theory, should have been trained to take care of people with multiple chronic conditions. And yet what they're seeing is that when they went to medical school in the 1980s or 1990s, they weren't really trained to take care of people with multiple chronic conditions, and yet they're now the senior leaders in their communities, or they're the senior professors in the medical school, and yet when they went to medical school, they weren't necessarily, at least they don't feel like they were well trained in taking care of people with multiple chronic conditions, because in the 1980s, 1990s, even probably early 2000s, most of the medical schools didn't really focus on that. And then we don't have a delivery system. We don't have a financing system. We don't have an insurance system that covers many of the services that they say people with multiple chronic conditions need. And so, they don't feel well equipped to do it. Turning to the next slide on multidisciplinary team use, there is a group out at Group Health of Puget Sound run by Ed Wagner, which is called the Chronic Care Model. And what Ed did was he started with diabetes, but he said, what are the characteristics of good care for people with chronic and multiple chronic conditions? And he has, if you look at it, in his model. He has a number of attributes, and this model has been adopted by the World Health Organization and other places. So it's become sort of the paradigm that people use and then build off on to design delivery systems for people with multiple chronic conditions. But one of the key attributes of a good delivery system for people with chronic and multiple chronic conditions is having multidisciplinary teams, because these people are seeing an average of 5 to 10 different physicians routinely during the course of the year to take care of their multiple chronic conditions in many countries. And if they're not coordinated, if they're not part of a team, they're essentially going to have people falling through the cracks, people getting drugs that don't work with the other drugs that they're taking, getting sent for unnecessary tests, getting different advice, all sorts of things. So we took a look at what countries did they think that they had multidisciplinary teams. And if you look at it, the United States, New Zealand, Australia, Canada, less than a third of the times does the physician practice in a multidisciplinary team. So the care coordination that they would get is a real challenge. In countries like the UK, where they've developed healthcare systems around multidisciplinary teams and have changed the system, the physicians feel very differently, and now you've got 80%, well, 4 in 5 of the physicians figuring, yes, they practice in a multidisciplinary team. So the healthcare system that's created can really influence on whether or not good care coordination occurs, whether or not there is, in fact, a multidisciplinary team to essentially get the care coordinated and get good medical practice.
Jerry, one question I have is around payment systems, and how could a payment system foster interactions between these teams or even between providers, like I see on your next slide? And are there any good examples of where this might be happening around the world now?
So the answer is yes. So let me go through and just talk about that question in a larger context on focus of care coordination. So you have at the center the patient, and then you have around the patient is the multidisciplinary team that's taking care of them, and that will include the lab technician and the X-ray technician and the person doing those, the myriad of medical specialists that are involved, the nursing home if they have some kind of disability, home care, the hospital, the primary care physician, everybody engaged in this. Now, in terms of a payment system, what you need to have is a payment system that gives incentives for the various doctors, the various hospitals, to share information, to share knowledge about the patient, to work together. In most cases, we're still working under a fee-for-service system, and the fee-for-service system gives virtually no incentive to work together to take care of that particular patient. Everybody does their own thing. Hopefully they do it incredibly well, but there is just no incentive to work together to provide care for the patient as part of a multidisciplinary team. And so what we're looking for is different models to try to create that multidisciplinary team. In fee-for-service medicine, we're starting to pay for care coordination in a number of countries to give the doctor an incentive. In the United States, we have some. France, there's some other very interesting models where they give the doctor incentives to work as part of the team and the patient some different cost-sharing arrangements to work as part of a team. So there's a whole series of arrangements that various countries are trying to do under a fee-for-service system. But then there's also countries like the UK that are really trying to do more of a program where it's more of a capitated system where the primary care physician is really the gatekeeper, but also to some extent the care coordinator, deliverer of funds. So the more of the money goes to that primary care provider who's now in charge of it and dispenses the money to the different providers based upon their interaction with the patient, their need for interaction with the patient. And so it's trying to use that payment incentive coordinated by the primary care physician to, in fact, provide better care coordination. There's a whole series of other models that are out there as well, three or four in the United States that you may have heard of. One is accountable care organizations, where the United States has put about $1 billion into these accountable care organizations. We'll probably spend more. And these are hospitals and physicians working together to provide better care, better outcomes, lower utilization, and there will be shared savings if it occurs. So the insurer will get some of the savings, and the provider will get some of the savings. And it's really a community orientation kind of thing. Another model is something like guided care. And what guided care does is it targets people with 3 or more chronic conditions. It provides money for a nurse that's sitting in the doctor's office to do the care coordination. The doctor is perceived not to be the best care coordinator, but the nurse is, and it's hospital insurance companies paying for this nurse care coordinator. Another model is transitional care, and that is an attempt to take care of when it's very expensive for these people with multiple chronic conditions, when they're going from hospital to home, when they're going from nursing home to hospital, when something is changing in their routine, everything gets disrupted. They could be put on different medications. They're undergoing a fairly major transformation, and in these transitional care programs, they're essentially giving extra attention, a nurse assigned to this person in these types of settings. And then finally, there are other programs which are focused on the patient that's nursing home eligible who has typically multiple chronic conditions and often disabilities, and they're changing the financing incentives in those countries. Countries like Germany have done the same thing with their programs, where they give the person the equivalent or some percentage of the equivalent of the nursing home money, keep the person at home because the person would prefer to be at home. They can do it less expensively, but they have a need for this long-term care service. So everybody's sort of trying to do this in a slightly different way, focusing on a different aspect of the patient population with multiple chronic conditions. I think they're all good ideas. They're all different targets. We're going to see which one of these works the best in the long run. In terms of practice guidelines, what we essentially see is that we need to not continue to focus on a single chronic disease, which we're doing, and we're doing incredibly well in many countries, putting a lot of money into things like pay for performance and whatever. But what we haven't seen is a lot of effort in trying to develop quality guidelines, practice guidelines for people with 2, 3, 4 different chronic conditions. It's very hard, very complicated, but at the same time, it's the norm of practice. And to say to the person who has these 3 things, you should get all of these things simultaneously, sometimes doesn't make sense. So to give you an example, often, they say you should get a colonoscopy every 5 years, and that's probably true for many people. But if you really have a whole lot of things wrong with you, you might not need to get a colonoscopy when you have other things wrong with you, because colonoscopy is quite disruptive, etc. So, there's a lot of people that are arguing that certain kinds of very important, very necessary preventive services might not be appropriate for everyone at all ages. And we haven't really worked through those kinds of arguments to try to figure out exactly what to do. That's sort of where we are today, and I'm more than happy to answer any additional questions.
I think we've just had one typed into the Q&A box. One of our participants asks, have you begun to uncover any trends in terms of which disease combinations are most prevalent and or costly?
And the answer is yes, we have. And if you go on a website for the Kaiser Family Foundation, you'll see some of the work. The problem with it is that there are so many different combinations and permutations of chronic conditions that it's just one massively large table. And so it essentially shows that there are specific combinations, but trying to summarize that into anything meaningful is almost impossible, because, just again, to give you an example, what you see is somebody has COPD and diabetes, and let's assume that's an expensive combination. But most people don't just have diabetes and COPD. They also have Alzheimer's, or they might have something else wrong with them. And that puts them into a triad, or a 4, or a 5, or whatever. So just looking at these things as dyads is really misleading, because very few people are just combinations of one or two things, especially the most expensive people. So if you look on the Kaiser Family Foundation website, you'll see this very elaborate, very complicated table. At least it makes my eyes hurt. I don't know what it will do for you, but the information, they've gone through it and taken a look at that issue.
I have another question here, and this is actually taken, I think, from one of your articles. And the quote says, good chronic care means ambulatory and not hospital care, and is often less technologically driven. So the question coming out of this is, how can the healthcare industrial complex be dismantled? And this might best be exemplified through things like medical tourism.
So I don't know that we're going to dismantle it. What I think we're going to need to do is to recreate it. And what we did in the 1900s to 1950s is to really focus on infectious diseases in most industrialized countries. And from 1950 to 2000, we focused on acute illnesses in most industrialized countries. And what we're having to do in 2000 to 2050 is to focus on chronic and multiple chronic conditions. In the lower and middle income countries, we followed that same timeline, but we're just doing it a little bit later. But most of the low and middle income countries are, in fact, catching up to us in terms of the prevalence of chronic conditions, as we showed you in that first chart. Now, medical tourism is a possibility. The problem is, with chronic conditions, you really can't go to a foreign country to get your chronic condition taken care of, because you're going to need to be there for the rest of your life. If you're going to get going to India, if you're going to Mexico, if you're going to someplace to get your chronic condition taken care of, you're going to have to stay there, because you're going to need care this week, next month, and next year. So I think the medical tourism works incredibly well, or could work incredibly well, for hip replacements, knee replacements, acute care kinds of things. But if we're talking about chronic and especially multiple chronic conditions, medical tourism might not be the best choice unless the person really wants to move and relocate and move.
Okay, I am Christina from the Basque Country, and we are carrying out some research about multidisciplinary teams and multimorbidity. And I wanted to ask to Gerard to know which will be the best target population if we could use those stratification systems as you have in the Johns Hopkins University to know which are the people who are better targets for these interventions, these multidisciplinary interventions.
Sure. So as I said just a few moments ago, there's really 4 models that are the typical targets. One is sort of the community, and these are the ACOs, the Accountable Care Organizations. And so if you look at that on the literature, you'll see lots of examples of accountable care organizations. We at Johns Hopkins have one, but I wouldn't say ours is necessarily the best. There was a very nice set of articles in a journal called Health Affairs, which summarized the literature on the accountable care organizations, and so I would take a look at that. The second thing is the issue of identifying people with 3 or more chronic conditions, and there's a lot of models out there to try to do it. One is called guided care. A physician at Johns Hopkins, who's now actually left, but a physician at Johns Hopkins, Charles or Chad Bolt, Boult.
Yes, I know him.
Oh, good. So Chad, he's the one who did guided care, and that had some success. It also had some concerns. Transitional care focuses in on people who are going from hospital to nursing home and whatever. Mary Naylor, Naylor, is a nurse at the University of Pennsylvania School of Nursing, and she has been designing this system around the United States because, many people who go into the hospital, when they're leaving the hospital, are totally, completely disoriented because they've changed their routine, they've changed their medication, and they don't know exactly what to do. I don't know if you sat in on, discharge planning, but often the person is totally confused when they're leaving the hospital and they don't understand everything that's being told to them. And having a nurse, having somebody there who's not even a family member but an outside person really paying attention to it, and who does it on a daily basis, and then can go back to them 2 days later and say, this is how, this is what they told you, this is what you should be doing, are you doing it, do you have access to the medications, etc. Turns out to be quite cost-effective, but it's a different target. And then the fourth target is really the people who have dementia, who have disabilities in addition to these chronic conditions, and are nursing home eligible. And so if I look around the United States and around the world, these are sort of the 4 targeted populations that most of the people about multiple chronic conditions are doing. But I'd be very interested in learning what's going on in the Basque region or any part of Spain, because, you guys have been, along with the UK, some of the real leaders in dealing with multimorbidity. So I'm very encouraged and always interested in learning what you're doing.
If the predictive systems like ACG or this, we are using this Johns Hopkins University stratification system. That's what I was asking you about. And now in our next project, because we are making a project like guided care, but with all those targets you said, that transition medicine based in the chronic care model. So we have a program that has all these ingredients of the chronic care model. But at first we work for patients who were admitted for heart failure. But now we want to work with patients who have a predictive index higher than 10, for instance. And my question was if working with these patients who have this predictive index, high predictive index, because they are in the top of the Kaiser Permanent Pyramid, you can make this kind of programs for them, no matter which are the combinations of conditions they have.
Essentially, what she's talking about is there's a number of ways to group patients into their severities. Yes. One is ACGs, who are ambulatory cost groups developed at Johns Hopkins. There's other ones as well that have been developed all over the world. And the answer is yes, we have developed things based upon the level of severity of the patient as a categorization. And that's really, to some extent, what Chad Bolt did in his guided care model, where he went after the most complex patients. He did it on the count of the number of chronic conditions, but he also did it using ACGs and other kinds of things. Now, the challenge in doing so is what ACGs and all these measures do is say who's likely to be the most expensive in the coming year. And that's clearly an important group to focus on. But sometimes the most expensive person is just going to remain expensive because no matter what you do, they're just going to be very expensive. So somebody on end-stage renal disease, they're just going to be expensive almost no matter what you do. So what you've got to do is look at that list of people that are going to be very expensive and then pull from that the ones that are more likely where an appropriate intervention is going to reduce their expenditures. And that's the $64,000 question that we've been trying to deal with. And that's the issue of targeting those people who are going to benefit most extensively. And that's an issue that most people have not been able to do incredibly well. And in my experience, when these programs have failed, they have not done a particularly good job in targeting those people most likely to benefit. So you do want to start with the most expensive people, but at the same time, you've got just to look at the list and say, but there's not much we can do to improve the care, to reduce the cost in somebody with these conditions, because whatever we do is just going to be very expensive and is not going to, their quality of care is not going to improve.
Jerry, I think we've got time for one last question. And John Parks writes in asking about comorbidity with patients with mental health problems. And have you found a mental health problem with a disease to be more costly?
Oh, almost always. And depression is probably the most common comorbidity related to increasing the cost. Some mental health illnesses are more expensive, but if we look at it, because depression is just so common in so many countries, that we essentially see that it's probably the thing that we worry about most as a comorbidity. But then as you get older, the mental illness that is the most problematic is obviously dementia, Alzheimer's, and that. So it depends on what age you're talking about. But it typically adds about 20 to 25% of the cost and makes compliance with treatment modalities much more difficult. So not only is it more costly, but it's harder to get people to do appropriate care. And then obviously if they're seriously mentally ill, then you really really have almost no compliance with appropriate care for their diabetes or whatever, and you're in a totally new ballpark. But again, we're really focused mostly on depression and Alzheimer's and in different age groups.
To be cheeky, one final question, because I think this ties up our conversation quite nicely. Ryan writes in, what role could there be for patient-focused outcome measures vis-a-vis multimorbidity, and what are the most insightful measures?
So patient-focused outcome measures are absolutely critical to do this because most of the outcome measures we have right now are clinical measures, and they're absolutely important, but people don't respond to clinical measures often. They respond to what they perceive to be the needs and the good and the bad care that they have. And the more chronic conditions you have, the more likely you are to be critical of the healthcare system, maybe appropriately, maybe not, but you tend to be much more critical of the healthcare system. And so trying to figure out ways to get that population with multimorbidity to be engaged in their own care so that their care will improve is absolutely critical. So patient-focused outcome measures, absolutely critical to develop, but to develop around the person who has multiple things wrong with them. Most of the surveys that I've seen, not all, but most of the surveys and measures I've seen really are focused on either healthy people or people with one or two conditions, not the complex, complicated patient, and that's where the work really needs to be done.
As our time draws to a close, I'd like to extend a big thank you to everyone for joining us and contributing to the discussion. In our next webinar, we'll be exploring the links between multimorbidity, mental health, and social deprivation, so please look out for the invitation coming to you soon. So thank you very much, Jerry, and thank you to our listeners, and we look forward to welcoming you the next time.